afternoon, ladies and gentlemen. This is a short and sweet chapter on mobile radiography. A lot of this is just adapting the positions you already know to the mobile setting and the particulars of the mobile setting and some of the pitfalls and traps that techs walk into when they convert an exam to a mobile exam. So the machine operates just the same. Technique setting is very much the same, especially with the big AMX4 like we see here. Most fun fact, most of your portable machines do have a motorized drive mechanism, but they also have a governor for that drive mechanism that is set such that you cannot run over little old ladies in wheelchairs in the hospital hallways with your portable machine. So you notice that it gets up to a certain velocity, about walking speed, but it doesn't go fast. No matter how hard you push, it doesn't go faster than a certain top speed, and that's because it's been set by a governor, which just limits the current running to the motor, such that the motor can only spin the wheels so fast, no matter how hard you press. So I don't think you can do a wheelie with a portable machine. I think the mass is fairly well balanced, but I have known that especially the AMX4 can be surfed, provided the person surfing the machine has sufficient wrist strength. You can self-propel by sitting on or holding on to the portable machine as you push the drive lever in. So, no, I'm not going to teach you how. That's unsafe. All right. So our objectives today, we're going to talk about the principles of mobile radiography. We're not going to talk about screwing around in how to surf a portable machine. You can figure out how to misbehave on your own time. Describe the basics of mobile x-ray machines. Well, it's the same as a conventional machine. It's just necessarily everything has to be portable. So it'd be nice if the generator was downsized and the internal electronics were downsized. Such that it could be put on top of wheels and be a self-propelled or at least assisted propulsion mechanism. And then you just need an x-ray machine that's on a crane type mount that you can position the tube in various orientations in order to facilitate capture of diagnostic radiographic images in a portable setting. Explain and demonstrate proper patient positioning for mobile projections presented. Well, we're going to walk into I don't really do that justice. I'm going to explain to you how to do a chest x-ray portably. That's about it. Demonstrate proper central ray and image receptor relations for mobile projections. They're the same as for routine radiography in an exam room. You just have to use your imagination a little bit more and figure out, because sometimes you can't move the patient. So mobile radiography and trauma radiography overlap quite a bit. Okay. Structures shown in each projection, you still should be able to image critique mobile exams just like you do exams in the exam room. Analyze radiographs of essential projections by applying evaluation criteria. Yeah, you should be able to image critique the exams you do mobilely just as well as you can image critique the exams you do in the exam room. Right, so mobile radiography uses a transportable X-ray source or X-ray machine to bring imaging services to the patient. This was first, actually the concept of mobile radiography was first tried out by, among notable people, Marie Curie in World War I. And in fact, that's one of her trucks. That's truck number 29. She built over 100 trucks for the French and Allied forces to use as field hospitals, and it looks like the generator is right next door. There's some kind of machinery under that tent next door. So the exam room was actually on the back of the truck, and it might be just for safety's sake, so they moved the generator outside immediately next to and that allowed for more room for examination within the truck. So that's the first mobile X-ray unit is on the back of a pickup truck in World War I. And Marie Curie oversaw the design of several of these mobile truck units. Nowadays, when we mean mobile radiography, it's not an entire truck necessarily serving at the battlefield or serving just um, just off of the battlefield. We're talking about moving the X-ray machines around the hospital to accommodate patients that can't come down to diagnostic imaging for their X-ray exams, to assist in areas such as the intensive care unit, surgery, recovery rooms, nursery, and neonatal units, all containing patients that it's really not wise to move them around the facility um, because of their health well-being, sometimes because of their status as a neonate, so on and so forth. Okay. So necessarily, when you do mobile radiography, you're going to be working with patients that have some kind of limitation or compromise to, commonly it's a limitation or compromise to move around and to ambulate very well. That's typically the reason um, that we do studies mobile rather than down in the exam room. Um, so mobile x-ray machines, some machines do have preset APRs. That is, you hit chest, and then you hit large patient, and then you hit AP, and it dials up a technique for you. That's like a programmed technique chart within the software. Others are just bare bones, and they have a KVP plus minus, and they have a mass plus minus. Um, and you just set the technique according to what you need. And then still others are stripped to bare bones. This is actually an x-ray machine that you see here. This is a true mobile x-ray machine. This is a capacitor discharge unit, and the generators inside that aluminum frame box with the black panel right there. That is the guts. That's the power supply and capacitor array to power the x-ray machine through the exposure. Okay. I think a little bit of the generation is actually in the yellow box above the x-ray, but it's a stationary anode with a collimator. Capacitor array saves. If you have a capacitor array, you can use a smaller step-up transformer. You can use microelectronics, so long as your capacitor array is robust enough. You can plug into the wall and after a certain amount of time store enough charge proportional to the voltage spent on a kilovoltage exposure. So you just have to have enough capacitors, and that's what the black box there is for. So this one, you can see the little caster wheels on the front and then the bicycle tires. This entire machine is meant to, once you fold the laptop up, it's meant to be carried from nursing home to nursing home in the back of a van so that you can do on-site x-rays of nursing home patients and other patients that are in confined areas or limited mobility areas rather than pay for an ambulance ride back and forth from the nursing home to the hospital and an emergency room visit. It's actually more cost effective to bring a capacitor discharge machine to the nursing home and do preliminary x-rays to make a determination whether or not the patient needs to discharge to the hospital. So it saves nursing homes money to bring the x-rays and the lab facilities to them. Okay? And that's commonly done at nursing home facilities and assisted living facilities across the nation. Nowadays, our mobile units are direct digital capability. Most of them have flat panel detectors. Some of them have the new wireless flat panel detector. Don't lose that thing. Most of them also have either Ethernet tether, DICOM download to the hospital packs or wireless Bluetooth like or shortwave transmission to the hospital packs via the Wi-Fi network. Um, I've worked with both of those settings. Um, they did not approve wireless detectors until after I left the clinical setting, so I haven't had the opportunity to work with a wireless portable detector. All right. Anode heel effect. Mr. Shepard is going to be covering this if he hasn't already, but in essence, because we use a big metal wheel or a big metal wedge, if it's a stationary anode machine, um, some of the metal target made of tungsten and molybdenum actually reabsorbs the X-ray beam before it gets a chance to leave the tube. Okay. For this reason, the heel, we have this thing called the anode heel effect, and it's not the top picture. That's getting your shoes properly fitted back in the 1930s. They used fluoroscopes to give you a lateral projection of your foot inside of a shoe, and to show you how it fit. No, the anode heel effect means that the beam thins out on the anode side because of the metal that the anode is made out of reabsorbs some of the X-ray that is created. So it doesn't even get a chance to escape the anode itself, and it's reabsorbed. And it just that adds to the heat of the anode, but it also thins out the beam on the anode side. Well, this is exacerbated with short SIDs, larger field sizes, and smaller anode angles. Okay, now 2 of the 3 of those are guaranteed in the mobile setting. Okay, if you're in the mobile setting, hospital rooms are small. They're unbelievably small. They're closet sized. Okay, so even though the projection calls for 72 inches, good luck getting 72 inches. You're going to be confined to 40 inches or less for most of your mobile exposures. Because of that, the anode heel effect is going to be exacerbated or more pronounced. Also, larger field sizes, which also lends itself to the mobile setting. Typically, you open the collimators just a little bit wider. It's just a subconscious thing when you're doing mobile radiography than when you're doing radiography in an exam room. And it's because you have manual control over the collimators in the mobile setting versus you have, what are those called? The automatic collimators, the positive beam limitation software, the auto collimators in the exam room. So the auto collimators tend to keep your X-ray beam collimation under control a little bit better than manual collimators. We're nervous creatures. We don't like to clip things. We open collimators. That's what we do. Okay. So with short SID and large field sizes in mobile radiography, you're going to get more pronounced anode heel effect. Okay. So be sure that when you're shooting, that you're aware of the anode in a mobile setting, that you're aware of the anode heel effect, and that you're properly aligning the long axis of the body and the tapering anatomy, if you are imaging tapering anatomy, with the anode cathode axis of the X-ray tube in order to take advantage of the anode heel effect and get a more uniform distribution of the X-ray beam across the tapering anatomy. If you forget, the way to remember is cat fat. Put the fattest or the thickest portion of the anatomy underneath the cathode. All right, grids, optimum performance. You're going to be putting on a stationary cap on or slide on grid. Oh my goodness. Pausing the phone, or pausing the recording. Hang on. Oi. All right, back guys. Phone doesn't ring until I try to make a recording, and then it just rings off the hook. So, you're going to be putting on a snap-on or a slide-on stationary grid. Well, that behaves a little bit differently than the grid you're used to working with in the exam room. In the exam room, the grid is actually built into the table, or it's built into the vertical bucky, and it oscillates on a motor. It kind of shakes back and forth during the exposure, such that it blurs the grid lines and you don't end up seeing the grid lines. Well, in a mobile setting, you might notice that you see grid lines, and the reason you see grid lines is because it's a stationary, non-oscillating grid. Now, the other nice thing about grids in the exam room is they are exactly perpendicular to the X-ray beam, so long as you're shooting perpendicular to the table or the vertical receptor, you're also shooting at a perpendicular to the grid. Now, in the mobile setting, your snap-on grid, it is going to be very, very difficult for you to get that thing exactly horizontal. Okay, so if you're utilizing a snap-on grid and then you got to slide that under the patient's pelvis or abdomen, there's a hole in the mattress. Why is there a hole in the mattress? Well, because it's a hospital mattress, so it's 8 years old. So over 300 people have slept in that bed of various weights. Okay, there's a hole in the middle of the mattress. The patient will sink into the middle of the mattress. If you try to put a grid under them and you're hoping that it's level underneath them, well, I'm sorry, it's not. Your grid is never level underneath a patient. So, if you don't compensate for that with your X-ray tube, then you're going to get cutoff, which you see in the picture on this slide. The primary beam radiation is going to be filtered out by the grid just as much as the scattered radiation is. And you're going to get cutoff because your grid is not level. Okay? So how do you fix that? Well, you either do a compensatory angle, which is fairly easy to do, or you expose yourself and you put your thumb on one quarter of the grid and push down on it to counter push where the patient's backside is pushing down on the other corner of the grid and try to make your grid level. The second maneuver gets you in close proximity to the patient while an X-ray exposure is going off. It is much easier to just compensate with your central ray to align it to be perpendicular to the grid rather than necessarily true AP or true lateral. Okay. Now this is going to get you possibly an oblique. Okay. How do you fix that? Well, you can also compensate your patient and slightly oblique them into the X-ray tube, and then what you get is you end up getting like a cockeyed AP. Okay. You may or may not have seen the technologists do this. Okay. Some technologists, especially in the digital age, refuse to shoot with a grid because they can't avoid grid cutoff. But I have shot many times with a grid. You got to know which way your grid lines are running, and then you got to just change the angle of your X-ray tube so you're approaching your grid at a perpendicular, okay, underneath the patient. So just figure out what plane your grid is residing in, and then match that plane with the face of your collimator. Okay. I'll show you what this looks like probably next week sometime. Radiation safety. All right, so you are in one of those situations, and the situations are this. You're performing an X-ray exam. A live X-ray source is producing X-rays while people that are not intended to get the X-ray are standing in the room. Okay, so notable examples of this are mobile radiography, surgery, and fluoroscopy. Okay, these also happen to be the types of exams that carry the highest occupational exposures for radiographers: mobile, surgery, and fluoroscopy. And the reason is simple. You're standing in the same room as an X-ray source that is creating ionizing radiation. Of course, your exposure is going to go up. Okay? But you can still limit it. Time, distance, and shielding. Can you get distance all the time? No. Sometimes you do have to hold. okay? Not as a student, as a registered technologist. So distance is not always doable for mobile radiography, okay? Shielding, always doable. Time, always doable. You can always shoot with a smaller exposure time. Always, okay? Well, until you change it, do the smallest exposure time possible, and then you can't. But you can control time and shielding. With a 6 foot long exposure cord, you can partially control distance. If you have the ability to stand outside the room, do so. If you do not, stand as far away as you can. Stand at a 90-degree angle to the primary beam and the long axis of the patient, or a 90-degree angle to the central ray. So, and I'll show you that. I think that's coming up. Additional components of radiation safety. Have you heard the techs shout X-ray when they're doing mobile exams? They should be shouting X-ray. Shield the patient's gonad when you're X-raying children, when you're X-raying persons of reproductive age, when the patient requests them, when the gonads lie in or near plus or minus, what is it, 2, I think they say plus 2 inches or so, or within 5 to 10 centimeters of the primary beam, you should shield the gonads. When the shield does not interfere with the anatomy of interest, okay? So if you're doing a female KUE, you can't shield. Minimum source to skin distance is 12 inches, okay? And that's because of the inverse square law. You could give a patient a radiation burn if you have less than a 12-inch SID. Okay, so just some notes of radiation safety, and always, 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 it's your ethical responsibility to notify other healthcare professionals when you are about to make an exposure, especially if you're in like the recovery room. If you're in the PACU, post-anesthesia care unit, you need to announce because there's all sorts of people going through there. Okay, I've even gone so far as if I had an extra shield and I was X-raying one person, but the person in the immediate stretcher next to me was of reproductive age, I'd be shielding that person while I'm taking the X-ray on the other person. Okay, because they can't change their position in the PACU. All right. Isolation. Two types of patients in isolation. Those who have contagious infections and you might actually take some of that to the next patient or to yourself or your children as you drive home or what have you. So the patient has an infection or a contagious microbe in their room, on their skin, in their mucous membranes, on their clothes, in their bed linen, whatever. There's the creeping crud is in there. Okay? You have to protect yourself from that. You need to don PPE. Usually there's signage telling you this patient's on this type of isolation or that type of isolation. You should heed those isolations. You should know what is the proper PPE for each type of isolation and don the appropriate PPE as necessary. Okay? The other type of isolation is what we call reverse isolation, immunosuppressed isolation. I forget what the other name for it was. Anyway, it's a compromised immune system. The patient has a compromised immune system. Either they're undergoing radiation or chemotherapy, or they're just really, really sick already, or they've had a liver transplant, or whatever. The patient is at risk from you bringing microorganisms in, things like coronavirus. Not the coronavirus we've been suffering from, the coronavirus and the norovirus and the rhinovirus that causes the common cold. You might have that on your hands right now. And it's not a risk to you because you've built up an immunity to it, right? But it's a risk to your patient that's undergoing chemotherapy because they injected her with poison 2 weeks ago and all of her white blood cells passed away. So the common cold could be deadly for that individual. So that's reverse isolation. There's also a specific PPE that you need to wear for it. You should be familiar with isolation considerations when you're going on mobile exams. You should heed those, okay? Um, if there's no signage, you really ought to be checking with the nurse on the floor with the patient. Just to, hey, I'm here to get the x-ray on Mrs. Adams in bed 217. She's not on an isolation status, is she? Oh yeah, she is. She actually tested positive for meningitis. It came back from the lab just this morning. I haven't had a chance to put the results in and hang the signs, but yeah, she's positive for bacterial meningitis. You need to follow um, standard precautions. You need gown and gloves, and you know what? A surgical mask would probably be good too. You need to don your PPE. Just check. Sometimes nurses are busy. Sometimes it's like that, where there's a pending lab result, and then that changes the patient's isolation status, usually right after you go in there to take the x-ray. So just double check with the nurse because the nurse probably knows. Oh, yeah, they're going to upgrade that one to an isolation. You better go ahead. So all it takes is a little communication on the front end, and you can protect yourself, okay? You should check in with your nurse on the floor, if at all possible, before beginning a mobile exam. You never know. Oh, that patient is scheduled to go for an endoscopy, and transport's going to be here any minute. What is it you're going to do? Oh, I've got a lower leg, an ankle, a knee, a femur, and a hip. You don't have time to get all that done. You better come back after the endoscopy. Okay. Check in with your nurse. They know things. Okay. Wash your hands before gloving. Protect the IR. If you're isolating yourself for one of those two reasons, you should also be isolating your cassette. You should have some kind of protective plastic, like a rad bag, that's a trademark name, or some such thing that you can wrap your image receptor in and isolate it from contact with the patient's and the patient's belongings, and then you dispose of that. It's a disposable protective sleeve for your image receptor. Okay. Additional considerations: if you do have two people on this job, you might consider a clean person, dirty person routine. The dirty person positions the cassette, gets the patient into the proper position, puts the image receptor behind the patient, and centers the image receptor to the anatomy appropriately, and also gives the patient instructions. Okay, the clean person sets the technique, drives the portable machine, and manipulates the X-ray tube, and aims at the image receptor, but does not touch the patient's bed, doesn't touch the image receptor after it's been bagged, and doesn't touch the patient. That way you have a clean and a dirty person. The dirty person is the one coming in contact with the patient, either directly or indirectly, and the clean person is coming in contact only with the X-ray machine. Now, what does that save you from? Well, it saves time wiping down the X-ray machine at the end of the exam. If you only have one person in an isolation, you'll need to wipe down the entirety, the control area, the exposure switch, the entire X-ray tube and crane. All of it needs to be wiped down if you only have one person. But if you got a clean and dirty system going on, okay, you should be able to avoid wiping down the collimator and the exposure switch and the controls for each and every patient. Now, if you suspect those surfaces has been compromised, you should wipe them down. But typically, in a clean, dirty person, it's reasonable to only wipe down the image receptor in between patients and then wipe down everything as you come back down to the department. All right, performing mobile exams. Check the battery charge on battery operated units at the beginning of the shift, not as you're going to do an x-ray, at the beginning of your shift. Okay? How do you know who you're going to sabotage? Who you're going to Shanghai with that dirty-handed maneuver? Okay? Leaving the portable machine uncharged. That's a really rude thing to do to a future technologist, the one that's going to be operating it next. How do you know you're not hamstringing yourself? How do you know you're not going to be the next one shooting a portable? Okay, so if the battery charge is low, charge it. Get into the habit of checking the portable units charges at the beginning of the shift. If any of them are unplugged and need charging, well, plug them in and charge them. Okay. If you're on bare bones charge up on the floor and you're trying to shoot a mobile x-ray, don't. Like there's going to be a battery indicator somewhere on the control area. If it's less than 10% of its total capacity, you really shouldn't be shooting that x-ray. Okay? You could have the entire machine could go dead, stone dead, midway through the exposure. Okay? So the modern machines have a software pop-up warning sign that disables exposure and tells you it won't allow you to expose until the charge comes north of 10% of total capacity or some such thing. Okay, the older machines, they will let you drive them until they're stone dead. Okay, so always be checking the battery power before you go anywhere with it. Before you enter the room with the machine, check the patient identity and the exam to be performed. Also check with a nurse to make sure that the patient's actually going to be there on the floor when you come up with the mobile x-ray machine, and that they're not going to their stat endoscope or surgery or whatever. Okay? Before you get the go through the trouble of setting up, confirm that you actually can do the exam. Okay? And that you have the right person. Okay? Communicate with nursing staff for proper patient care. Okay? The nurse will alert you to isolation precautions, even if they're not posted yet. The nurse will alert you to any kind of special considerations for the patient. Hey, you know that patient doesn't have a left leg, right? I didn't, but I do now. Thank you very much. That can get awkward when you're communicating with the patient and you tell them to stand or sit or whatever, or swing their leg over, or God knows what. Okay? So it's important to have a heads up on the special needs of the patient, and you get those from the nursing staff. Obtain nursing assistance if necessary. If you walk in there and it's 400 pounder and you're by yourself and it's an abdomen, you ain't getting that cassette. Don't fool yourself. You're not getting that cassette under there. Even with the patient helping, you're not getting that cassette under there. Okay? Some jobs are 2-person jobs. Some jobs are 4-person jobs. Figure out when you have a job that's bigger than you and ask for help. Okay? They might tell you to wait, but it's better than throwing your back out trying to get it done by yourself. All right. Move chairs, IV poles, wastebaskets, and other objects out of the path of the machine. So before you become a mobile radiographer, you are a furniture mover. You have to clear a space. So you should be thinking about the shot, thinking about where you need the x-ray tube to be, and then extrapolating to where do you need the base of the machine necessarily to be in order to get the x-ray tube where you want it. If the patient is examined in the supine position, move the base of the machine to the middle of the bed, that is halfway up one side of the bed. If they're to be examined upright, you can position the machine at the foot of the bed or the end of the bed with the x-ray tube coming over the patient's legs. For lateral and decubitus positions, place the base of the mobile unit parallel or perpendicular to the bed. Okay. Usually you just need the crane and the tube to be on the side of the bed. But you got to consider where to park as you're setting up your shot, setting your patient up, moving furniture around. Patient mobility. Never move a patient or part without assessment of the patient's ability to move or the ability to tolerate movement. Understand that some of the reasons you're doing mobile radiography is because the patient has lost the ability to move. Okay? So it might be that you have to adapt your tube and x-ray position in order to get the picture rather than moving the body part. Okay? Check with the nursing staff or the physician, obtain assistance when you need it, and obtain permission to move a part that has had surgery or is fractured. Okay, so if you see a cast in traction and you got to x-ray that, okay, find your orthopod. Doc, do you want me to take it out of the traction trapeze, x-ray it, and put it back in? Or do you want me to leave it in the trapeze and just do the best I can? Okay, you need an answer. You need clarification on that. Some doctors like it some way, some doctors like it another way. Okay. Inappropriate movement can further injure the patient, especially if you have a fracture that's been reduced but it's not healed yet. It's a fresh fracture. Every time his phone's ringing. If you have a fresh fracture, if you move that thing and manipulate that part too much, you can actually get it to displace. And that will make your physician very, very angry. So just be careful. Ask before you do. Don't proceed in the face of uncertainty. All right, fractures. There's a wide variety of fractures. Wow, you got to really work to do that. Okay, wide variety of fractures, therefore wide variety of range of patient ability to assist with the procedure. The key is to be cautious and gentle and to obtain plenty of assistance for patient safety and comfort. Okay, do not remember, there's a reason you're doing these mobile. The patient's ability to move is compromised. Okay? Assume that rolling into the room. Okay? Ask, model to the patient. You know you need to do, in this case, you need to do a 3-view hand. The best AP or PA that they can give you, which seems like this. A lateral, do you think they'll be able to do the OK sign? I don't think so. Okay? And an oblique. The oblique is even more valuable because the lateral is going to be a karate chop, essentially. And you know this. You know that they're not going to be able to manipulate their hand into a flare finger lateral if this is how the PA looks. Okay? You'll get a decent oblique, you'll get a decent PA, but you won't get a good lateral. Okay? Ask, model to the patient. Can you put your hand like this? Can you put your hand like this? Can you put your hand like this? Okay? Each time move your own hand and see if the patient can comply. Okay? Close enough. It's like this, we know we're not getting a flare finger. Okay? But can they curl some of their fingers and space them apart a little bit? Maybe. Maybe everything except for the third digit can move fairly well. A little bit of pain, but fairly well. If that's the case, I'm going to instruct them to leave the third digit straight and slightly curl the index finger, the ring finger, and the pinky finger. That is the second, third, and fourth digits. Do I have a perfect fan finger lateral? No, but I might get some separation of the phalanges. Interfering devices. Orthopedic trapeze. That's what's pictured here. You see all the piping there? Lately they've been making them out of aluminum. Depends upon the patient body weight, of course. You're going to need steel. Excuse me. You're going to need steel if your patient's over 200 pounds for a trapeze frame. Do not manipulate a trapeze frame. It can be disassembled. It shouldn't be disassembled for a portable study. You should not be undoing the locks or the clamps. Some of those bars are clamped in under tension. And when you release the clamp, the bar can actually bounce and then fall onto the patient because it's clamped in under tension or it's bowed. So just be mindful of that. You really shouldn't be manipulating an orthopedic trapeze at all. Okay, should be working around it. Okay. If you have the orthopod there or the orthopedic tech there, they can manipulate the trapeze, but usually they're not there for the procedure. Okay, you may have to shoot with an artifact in your image. You may have to shoot with a smaller SID than you would normally use. Okay? Always get assistance or at least ask a question about whether or not an object can be moved. Don't undo these clamps by yourself. If the trapeze falls because you undid a clamp, it'll fall on the patient, and that's your negligence. Okay? That is a lawsuit ready to happen. Don't do it. Positioning and asepsis. Okay? Warn the patient of potential discomfort of the IR. The IR is always cold and hard. You'll hear the text say that to each and every patient you do a mobile exam on. This board is going to be cold and hard. I've got to get it behind your back. The IR can damage skin of an older patient if they have really thin tissue paper like skin and they're sweaty. The skin can actually stick to the IR, and when you're trying to remove it, you can actually peel the skin and rip the skin of an older patient. So be careful. You should use a drop cloth or a flat linen sheet in between the image receptor and the patient if you suspect that their skin is going to tear very easily. Okay? Protect your image receptor from contamination by use of an appropriate disposable impermeable cover. Usually it's a plastic sheath, kind of resembles a garbage bag. All right, to do an AP chest, perpendicular to the long axis of the sternum and the IR, enters approximately 3 inches below jugular notch at the level of T7. Exposure made on inspiration unless otherwise requested. Okay. If respiration assistance is provided, watch patient's chest rise to determine inspiratory phase. Respiration assistance, they're on the vent. If the patient's on the vent, just time your exposure with chest rise, okay? Because the vent is going to breathe for the patient. So they're going to breathe in, they're going to breathe out. You're going to watch, and you're going to see the rib cage expand on the breathe in and then contract on the breath out, and then expand and then contract, and then you get on the rotor and expand and then contract, and then the rotor seems like it's leveling off. It's at maximum rotation, and expand and expose. See how I did that? It's called timing the breathing. If you're doing mobile studies, you're going to want to time the breathing, especially with folks that are on the ventilator and neonates. You want to try to time the breathing, and that's the hardest one because neonates, they breathe like 200 cycles a minute. It's like they pant like dogs, those neonates do. Okay? So time the breathing you best you can. Center at the level of T7 and the intersection of T7 and the mid-sagittal plane. Do not center at the nipples. That's sexist because sweet little old lady's nipples are going to be down here by her waist, down by L4. All right, if you're going to do a decubitus chest, make sure you build the patient up out of the mattress. Used to be we'd use a blank cassette for that, but now in the digital age, we only have one cassette. So you can fold up some linen and tuck it under the patient. That usually builds them up quite a bit. If you have a firm sponge, you can put a firm sponge under them too. You do want the lower rib cage up out of the divot in the mattress so that you can see the uh, hemithorax that's on the low side on your x-ray. Okay, so what will a decubitus chest x-ray look like? It'll look like this. So you got a horizontal fluid collection in this right lung down low, and it looks like they did get the image receptor low enough to capture that lower rib border right here. Okay, and then the black arrow indicates fluid in the lung of the patient's right side. Okay, fluid levels best imaged with affected side down. So if the patient has pneumonia, if it says patient has right pleural effusion or right pneumonia, that's going to be the decubitus chest. That is going to be the definitive image. That's going to show you this nice demonstration of an air fluid level. And you can, about T6 or T7, you can read it for like fractional volume of fluid. So you see how from the distance from the T-spine to the outer margin of the rib cage, that's a certain distance on this radiograph, and it looks like the fluid is about 1/4 of the way up. The radiologist is going to say on the report, looks like 25% opacity, because they're taking a reading of the fractional distance of fluid versus the total distance from the outer margin of the rib cage to the thoracic spine at about the level of T7. That gives you a fairly accurate read of a fluid volume as a percentage of total lung volume. About 25% full. Once you get above 40% full, the lung's really considered non-functional at that point. Neonate AP projection of chest and abdomen is often ordered. The infant is usually supine. Some bassinets have a tray to hold the image receptor. If the image receptor must be placed directly in the bassinet under the infant, make sure you wrap it with a soft clother. Usually they have a baby blanket that you can wrap on the clean linen cart. Take a baby blanket from the clean linen cart and cover the image receptor with a baby blanket. And then just dispose of it when you're done with the x-ray. Okay. Neonates get warm. They're under the heat lamps, just like the McDonald's French fries. If you're taking the x-ray, you're going to have to swing the heat lamps out of the way. Make sure you work promptly and efficiently, because the neonate could get hypothermic if you remove that heat lamp for too long. Okay, so get in, get your cassette underneath your neonate, then move your heat source, then bring in the x-ray tube, line it up with the cassette, collimate, mark, shield, shoot, and then get the x-ray tube out of the way, bring the heat source back in. Okay, that way you're leaving the heat source next to the neonate as much as possible. Okay, if you're doing multiple exposures, like a series, maybe you're doing AP a lateral abdomen, could happen. Maybe you're doing a decubitus with an AP. Okay, in between shot setups, swing the x-ray tube out, bring the heat lamp back in. Okay, you don't want the neonate to get hypothermic. Bad things happen. Lateral projection is usually obtained using dorsal decubitus position. So I've seen that both ways, actually. I've seen shoot it cross table. I've also seen, which is dorsal decubitus. I've also seen roll the patient up onto their left side if they can tolerate it. And usually the nurse does that. Okay. Elevate your infant on a radiolucent block if you're doing that dorsal decubitus cross table. Okay. You can use a cardboard box, like a Depending upon if the neonate is small enough, a box of gloves actually works pretty good to build the neonate up. Always cover with a baby blanket. Place the image receptor lengthwise and vertical besides the infant and immobilize. And again, this is for the cross table projection. Center the infant's chest and abdomen to the IR. Have nurse hold the arms and legs out of the collimated field. With the neonates, always have the nurses hold the arms and legs and pin the shield to the pelvis. Okay, you can use a standard thyroid shield to shield a neonate pelvis. Provide the nurse with a full-body lead apron. CR is horizontal and perpendicular to the image receptor. It usually enters on the mid-coronal plane. Exposure is made on inspiration. Timing of the exposure is critical. Infant respirations are rapid, so best effort is made. Try to time the respirations, okay? If they're on a ventilator, it's going to be a little bit easier. All right, that's the ins and outs of mobile radiography, guys. We looked at some of the equipment. You know that there's an x-ray tube, you know that it's on wheels, and you know the power generator has been miniaturized so that it can be deployed in a mobile setting. Okay, you know that the anode heel effect exacerbates with short SIDs and wide field of views. Okay, you understand that a lot of adaptation and communication has to happen on the front end before you make exposures in the mobile setting. You also understand that radiation protection shouldn't be compromised just because you're in the mobile setting. You can still control time, distance, and shielding to a certain limit. Okay, you should, to that limit, control your time, distance, and shielding, and your patient's time, distance, and shielding. Okay, we did have a couple radiographs, but just like conventional radiography in the exam room, mobile radiography, if you can image critique one, you ought to be able to image critique the other. Okay, not a whole lot of difference. Oh, and grid cutoff. We did cover grid cutoff too. That's our mobile lecture, guys. I'm going to send this to you straight away because it was due this morning.